Welcome to Emory's Living with MCI Dementia webinar series. We are so glad you could join us today. I'm Alice Cooper Salisbury. I'm one of the clinical social workers in Emory's Cognitive Neurology Clinic. I'm joined by my colleagues Ashley Varner, Debbie Arnold, and Jenny Gay. The topics today, we are presenting our topics that we have found that affect patients and families on their journey. So some housekeeping details about the webinar today. This is a webinar, so participants, your cameras are off and your mics are muted. We do want you to participate though. So please put your questions in the Q&A box at the bottom of your screen or wherever it's located. And there will be a time at the end of the presentation where we will answer them. So thank you again for joining us today.
And my name's Ashley Varner. I'm really excited to be able to introduce to you Dustin Abram. Dustin is the president and owner of Elite Driver Rehab, which is a mobile occupational therapy provider specializing in driver rehabilitation services for people of all driving ages throughout Georgia. Dustin is a board certified and state licensed occupational therapist, and he is also a certified driver rehabilitation specialist, which is the highest credential attainable in the field of driver rehabilitation. Dustin has extensive experience performing comprehensive driving evaluations and specialized in driver training, and he has been helping individuals achieve their driving goals with confidence since 2018. We are really fortunate to have him here today to talk with us about driving evaluations, when they're a good idea, and what's involved with them, and what the outcomes do and don't mean. So with that, I will turn it over to you, Dustin.
Well, hello, everybody. Thank you so much for the wonderful introduction. I'm just going to share my screen real quick, and we'll get into it. Okay. All right. So, as we're going to talk about ensuring safety behind the wheel. Okay, so understanding the importance of driving evaluations for individuals living with mild cognitive impairment and dementia. So the presentation objectives. At the end of the presentation, you guys will have a better understanding and be able to identify when people with MCI dementia should have their driving abilities evaluated, communicate the importance of a driving evaluation to these individuals, and then understand the driving evaluation process and kind of expected outcomes for these individuals as well. So to kind of set the stage and put a frame in everybody's mind of, kind of what driving is and what driving is not. So driving obviously is a very important form of community mobility, but it is not the only form of community mobility. Especially nowadays, there's a lot of alternative transportation options, so it's not the only form of community mobility. It's Driving is a high risk activity that is relatively expensive. It's very expensive to kind of keep a car up and going with insurance, car payments, maintenance, upkeep, so on and so forth, not even including the gas and everything else to keep it on the road. So it's a relatively expensive task. What it's not is a low risk activity that's inexpensive. So there's a lot of risk when it comes to driving, even for people with no cognitive impairment at all. I mean, you hear about accidents all the time. So it's a high risk activity. Um, it is a privilege granted by the state in which you live in which case ours is Georgia, that can be taken away, can be revoked, if a person is not able to do it safely. It's not a personal protected right. There's no amendment to the Constitution saying you have a protected right to driving, so it is a privilege. Um, And also, finally, driving is a complex activity that most people will eventually stop. And again, this is not just for people with cognitive impairment, it's people in general. Most people outlive their ability to drive by about 7 to 10 years. So, what it's not, again, it's a simple activity that's typically done for life. So kind of keep that in mind as we're going through these slides to, of what driving is and what it's not. So driving is, you know, primarily a cognitive task. I mean, there's movement involved, obviously, with using the steering wheel and the pedals and stuff, but it's minimal movement. It's not a lot of movement. It's mostly occurring in the brain. And most of the information that we get is visual information, which we'll talk about a little bit later. But 90% of driving is visual input that you're getting, and it's your brain processing all of that data to kind of make determinations. So the cognitive domains used for driving are mental alertness. Obviously, got to be alert to be able to see things, what's going on. Sustained attention, divided or alternating attention, being able to focus on multiple things at once, your speed, signs, things like that. Cognitive flexibility, set shifting, memory, executive function, obviously judgment, decision making, those kind of things. Um, Processing speed, visual spatial skills, and visual perceptual abilities. So there's a lot of cognitive functions that are needed for driving. So, obviously when we're talking about people with cognitive impairment and dementia, there's, these cognitive functions can be impacted and impaired. So some specific considerations for these, individuals with this diagnosis is, some states have different requirements for these drivers with these diagnoses. Like, for example, some states have triggers that automatically, if you get this diagnosis, you have to be evaluated. And some, like California, for instance, they automatically revoke your license if you have, moderate or severe forms of dementia, things like that. So there's no triggers in Georgia currently. So a diagnosis does not automatically disqualify someone from driving. However, it is a red flag or should be a red flag for family members and caregivers to kind of start the conversation about driving safety. Because again, driving is primarily a cognitive task that we're doing. The level of impairment and the progression rate should be considered. Um, New diagnoses, mild, like MCI versus, severe or late stage Alzheimer's, dementia, things like that, there's going to be vastly different in terms of, and it's all individual as well. So, as an OT, I look at everyone as an individual. So that's a big part of kind of what I'm looking at. Um, but the biggest thing about individuals with this diagnosis is kind of establishing a baseline of their abilities um, to kind of monitor their skills over time. Because as you may or may not know, these conditions are progressive. They're going to get worse over time. They're not going to get better. Uh, there's no, there's some medications that can be taken to kind of stave off and things like that. There's therapies and so on and so forth. But, it is going to progressively worsen over time. So, we want to monitor the skills and kind of make the determinations on what we can do to keep them on the road longer, maintaining their independence, but also determining kind of like when it's time to, decide when it's time to retire. Um, so another thing to consider is the client's medical history. Chronic progressive comorbidities create physical and cognitive challenges with driving in addition to the MCI and dementia. So, for example, diabetes, that's a common comorbidity. Um, it can lead to peripheral neuropathy or diabetic retinopathy, visual problems. So, you have to kind of consider all of the medical aspects. It's not just the MCI and the dementia. Um, Patients with acute medical changes, especially neurological changes such as stroke, those are the kind of people that, you want to take a look at, obviously, and have their driving evaluated because you have the MCI and dementia on top of now a stroke or other neurological changes. Um, and then also considering just age-related changes. Just joint stiffness can lead to decreased range of motion, generalized weakness, decrease in bone and muscle mass. Things like that can cause difficulties and problems. Like I said, visual impairments, cataracts, macular degeneration, just a normal function of aging, can also affect driving in addition to the MCI dementia. Um, Impaired balance and slow gait is another key indicator. So I do a rapid pace walk test as part of my evaluation. Which is a timed walking test that the patient walks 10 feet, turns around, and walks back. It's a good assessment to kind of see, their balance and their gait. And there's evidence out there that suggests that drivers taking over 7.5 seconds to complete the 20-foot walk were 2.5 times more likely than age-matched controls to be involved in an at-fault crash. And those taking over 9 seconds have a threefold increase. So there's also with falls, which is another aspect of gait and balance. There's a huge correlation between falls and driving safety. There's a lot of literature out there. So it's a key indicator that I'm looking at. The person has a lot of, especially recent falls within the last year or two. That's probably a good indicator that they need to have, their driving evaluate or their driving skills assessed. One systematic review examined associations between falls and motor vehicle crashes and crash-related injuries, driving behavior, and performance. Found that older adults who had fallen were approximately 40% more likely to experience a motor vehicle crash than older adults who had not fallen. It was also found that people with a history of falling drive significantly slower and have more instances of hard braking behaviors than those who do not have a history of falls. So we'll kind of get more into the driving aspect of things in a minute, but as you can expect, hard braking and driving slowly makes you a hazard in the road. So obviously you don't want those things. So um, driving is a high level activity of daily living, or an IADL is what I call it. It's not recommended as a viable option if the client requires assistance to do kind of basic activities of daily living, especially for personal mobility. If they need assistance to do those things, um, then it's probably not appropriate to kind of start looking at driving. Now, again, that's why we do the evaluation, but generally speaking, if they're having difficulties doing the lower level things, the higher level things are kind of not really or contraindicated. Um, if they're currently receiving therapy, then it's recommended that they kind of go through their therapy process, get as much recovery as they possibly can before they attempt to return to drive. Um, it is possible, driving is possible for people that require assistance with IADLs, so instrumental activities of daily living, because they're a little bit more higher level. So, for example, um, if they require assistance for medication management or financial management, they have things in place to kind of help with those things. But, if they are requiring assistance, again, it's probably a good idea to see if they're able to do driving, because that's a very high level IADL. But if they're not doing IADLs, especially for safety reasons, like cooking, for instance, they can't be alone to cook because there's safety concerns, then obviously driving would probably be contraindicated in that situation. If the patient is currently driving and they're doing so independently, or they're relying on a co-pilot, which is not very uncommon. So a co-pilot is relying on someone else to ride with them. Um, that's not really recommended in terms of maintaining safety on the road. Using a co-pilot for navigation purposes is a very good compensatory strategy to help with navigation assistance, but it's not recommended for driving, keeping people safe on the road because the co-pilot may not be trained to intervene for safety, or oftentimes they can't intervene for safety because they can't reach a pedal in a pedal misapplication or something like that. So, not really recommended for co-pilot outside of navigation assistance. Driving history and their habits are a big one that I look at, which you should also be considering. So recent traffic accidents or citations, kind of like within the last 3 to 5 years, are kind of a big red flag. But you got to consider many accidents are not reported to the police, especially if they occur in parking lots. Police typically won't issue a citation, and accidents are often just kind of a handshake between the two people that happen, especially in minor accidents. But those minor things kind of add up over time because why did that minor accident happen, you know? So it's important, especially vehicle damage. If there's vehicle damage, unexplainable vehicle damage, that should be a warning sign of, hey, this wasn't like this before. So many patients are reluctant to tell family about accidents that they have, especially those solo accidents where there's no police call, nothing happened, and they just drive away because they hit a mailbox. Um, or they just forget. Again, if they have memory problems, they might just forget that that happened, and they have no idea what happened to the car. So that's a big one that I look at, and that's why I look at the car whenever I do evaluations. Citations, if there are any citations, they're important to note because they could indicate underlying issues that align with the common warning signs, such as failure to maintain a lane or failure to yield, things like that. Um, One or more instances of getting lost or turned around, especially in familiar areas, is a significant red flag that a person should be evaluated. This is a big one for this population specifically. They have difficulties with kind of nuanced situations. So, oftentimes I hear people say, well, I just want to be able to drive to these couple of little specific places. Well, then I say, okay, well, what happens in a nuanced situation where that road is closed for construction and you have to go on a detour? Can you manage that detour without getting lost and turn around? And, most accidents happen within, 5 miles of your home. So just because, it's close, they only want to be able to go, to close places near their house doesn't mean you can't get lost, turned around, or have an accident. So if there's any of these instances, then that's a significant red flag. And then, demonstrating common warning signs of unsafe driving, which we're going to get into right now. So a lot of people ride the brakes, stop in the middle of traffic, which I talked about a little bit earlier. That's a big warning sign, especially if they're kind of lost, turned around, or they're trying to orient themselves to where they're at. They'll do that a lot, riding the brakes and looking around and stopping in the middle of traffic, kind of just unaware of what's going on around them. That's obviously very unsafe, creates a hazard in the road. Driving too slow for the flow of traffic, which is kind of a follow-up to the first one, driving very slow, riding the brakes. Um, does not notice or react appropriately to traffic signs and signals. So just completely oblivious to the speed limit, driving very slow under the flow of traffic, people honking at them and they're not seeing what's going on. It's a big warning sign. Poor road positioning, so weaving, drifting out of the lane, wide right turns, short left turns. These are potential issues that can cause, obviously, traffic accidents. So, poor road positioning is a big one. Failing to yield or take right away appropriately. So, not knowing what to do at, 3 or 4 way stops, not knowing what to do at yield signs or traffic circles, things like that. They get easily frustrated or confused while driving. Again, especially whenever they get turned around, lost. Um, Fail to respond appropriately to road conditions ahead. So, A big one is not realizing they need to be in a certain lane. So, for example, if they say they should have been in the left turning lane, but then they just turn left from the straight lane. That's obviously a safety hazard. So they're not reacting to what's coming up ahead. Um, Near misses, close calls or near misses, they're not reported, but that's a big deal. If you see those things, that's a big problem because those near misses could turn into accidents in the future. Confusing the pedals or pedal misapplications, hitting the gas when you're thinking you're on the brake. That's another one. And then obviously poor judge of gaps in traffic when turning or merging. So thinking you have plenty of time and they pull out very slowly when a car is coming quickly. So that's a big one. Family caregiver report is a big thing as well, which is important for you guys to consider, because the patient's self-rating of their driving safety or ability is insightful in terms of, what kind of executive function do they have? Do they have poor insight? Do they have good insight? Do they have good awareness, poor awareness, that kind of stuff? But it shouldn't be relied upon. You shouldn't rely on them saying, oh, they think they're fine, because again, they have cognitive deficits. So, if they have impaired judgment, impaired insight, they might think that they're totally fine, or they've been driving for 40 years and they've never had an accident and everything else. So, their self-rating should not be relied upon, but obviously listened to. So caregiver reports about their loved ones' abilities, of not just driving abilities either, just their abilities in general. I mean, it's very important. Caregivers often have valuable insights about their loved one's driving ability, especially if they've witnessed many of the common warning signs I just mentioned previously. And a caregiver who reports that their loved one's driving ability is unsafe is a good indicator that they are a high-risk driver and should be evaluated. Um, Another big red flag that a person is high risk driver and should be evaluated is if their caregiver no longer rides with them or family members no longer ride with them, or they don't allow their children or grandchildren to ride with them due to safety concerns. So it's a big deal in terms of family caregiver report of what they will and won't do. Because oftentimes whenever I see people, I talk to the caregiver and they're like, I'm not getting in the car with them. So that's a big red flag. If you're not getting in the car with them, it's probably because you think there's a safety issue and they should definitely be evaluated. For caregivers who are still willing to ride with their patient, like I said, most are not. The fitness to drive screening measure, it's a great evidence-based tool to help identify if their loved one is at risk. It's a web-based questionnaire developed by the University of Florida. Consists of 21 questions that the caregiver completes based on their on-road driving observations with the patient. And the results identify the patient's level of risk and provide recommendations for next steps to take. So if you are still riding with your family member and you have a concern about their safety, absolutely, I would recommend doing that, just to kind of get some objective data on what you think next best step should be. So we kind of talked about all the different things of reasons why someone should be evaluated. So good candidates for an evaluation obviously is someone who has been diagnosed with mild cognitive impairment or dementia. If for nothing else, to establish a baseline so that we can assess their abilities over time. Um, if they have any acute medical changes, especially neurological, poor balance, slow gait speed, history of one or more recent falls within the last couple of years, visual impairments, they require assistance or are unable to do activities of daily living, especially due to safety concerns. They have recent history of one or more traffic accidents or citations. They have, one or more instances of getting lost or turned around while driving, especially in familiar locations. They demonstrate any of the common warning signs of unsafe driving that we mentioned earlier. And then finally, if their family or caregiver reports that they're unsafe or refuses to ride with them, doesn't allow their children or grandchildren to ride with them, that's a big red flag that this person should probably have their driving skills evaluated. So, okay, well, what's the next step? You've identified they need to get an evaluation. So, communicating the need for a driving evaluation requires advocacy and awareness about them as an available option to the patient's physician because a referral is required for an OT driving evaluation. However, many physicians may not be aware of a driving evaluation as an available option, especially in rural areas of the state. Most driving rehab programs are located in Metro Atlanta, so further out, they may not even be aware that there's a driving program available to them. Um, also physicians make the final determination about whether a patient is safe to drive or not. But they're often reluctant to make that determination because, they just don't have the information available to make an informed decision. So they're going to err on the side of caution a lot of times and, just say stop driving or recommend that you stop driving. But a driving evaluation could, help keep them on the road longer, maintain their independence. Um, many patients who are told to stop driving by their physician, like I said, they can maintain their independence and resume safe and independent driving for quite some time after being evaluated. So I encourage you to talk to your family member's doctor about spreading awareness and any of the healthcare support staff who are working with family members who have MCI and dementia on, the availability of a driving program and a driving evaluation wherever you may be. So, what are some benefits of the driving evaluation? So it offers reassurance, peace of mind to the patients and their family caregivers by alleviating concerns about safety, and it helps physicians make informed decisions about the patient's driving abilities. Like I said, they don't know because they're not in the car with them. So it helps make a better determination on why they're saying stop driving or okay, you can continue driving. Um, the evaluation maintains the patient's dignity by giving them an opportunity to demonstrate their driving abilities in real-world driving scenarios to show that they can safely drive, rather than just assuming that they're unable to because they have a diagnosis. Um, so, they're also performed by an occupational therapist, someone such as myself, who is trained to examine how medical conditions and impairments can affect task performance. And they make personalized recommendations such as compensatory strategies or adaptive equipment to help keep patients on the road longer. Um, because again, I always tell all of my clients that, I'm their advocate and we act as an advocate to maintain the patient's independence for as long as possible. We want to assist them and their caregivers with also, helping them kind of work through the transition to driving retirement whenever that comes about. Um, and driving evaluations performed by state representatives or driving schools are usually done by people, who are not trained to address medical situations appropriately. And they typically, just provide a pass-fail grade of you can or you can't, with no real options of, okay, well, is there any kind of training or other interventions that can be implemented? So the most important part of addressing driving safety for people with MCI and dementia is just starting the conversation. Um, it should be done as soon as possible, preferably when the diagnosis is made, as soon as it's made. So obviously, the best time is to start the drive or start the conversation now, but it's whenever you are able to, is you should start it as soon as possible. Many family members and medical providers avoid talking about driving safety because they're unsure of how to navigate the subject or they don't want to create an uncomfortable situation. But it's an important conversation that needs to happen for the safety of the patient and everyone else on the road. So you got to kind of consider that because again, going back to the initial framework that I put in is driving is a privilege. It's not a right. So if there's safety concerns involved, then they need to be evaluated. Um, Initial conversation should not focus on trying to get the patient to stop driving. It should be about rather informing them how the condition is going to affect their driving performance. Such as the common warning signs. How their condition affects their cognition. Obviously, not everybody, depending on their level of understanding and the level of their condition, they may not necessarily understand that, but at least, try to inform them. Um, and then gather information about, the patient to identify if they're appropriate for a driving evaluation. Like I said, if they have the diagnosis, we already know that that's an appropriate reason to get an evaluation just to establish baseline. However, get some more information to determine, what other things, because the more the information that you could provide the OT doing the driving evaluation, the better off they'll be in terms of knowing the full picture of what's going on, with your loved one. And then, obviously discussing the benefits of the driving evaluation. Like I just mentioned before, focusing on that. It's about maintaining their dignity and their independence for as long as possible. Um, but, the conversation should not shy away from the fact that, there is going to be eventually driving retirement. Like I said, it's going to happen from everybody. Most people are going to retire from driving. They're not going to drive forever. So, you know, so start that conversation and just, kind of ease into it about, this is going to be an inevitability. Um, you can also suggest a driver planning agreement, which is what you see here. This is an example of one off of AOTA's website, and it's basically just a contract between the patient and family members, caregivers that kind of details all the options that must be explored by the caregivers to try to maintain the patient's driving independence for as long as possible before they're allowed to request that the patient retires from driving. Um, a driver planning agreement is a great way to prevent potentially contentious conversations about driving, especially once the condition progresses into later stages of impairment. And the impairment becomes more significant. You can always refer back to this document um, when the difficult situations arise, which we'll talk about in a little bit about difficult situations. It's not a guarantee, obviously, that the patient will follow through with the agreement, but it's a good tool to show that you have their best interest at heart and you want to try to maintain their independence for as long as they're able to safely do it. Um, so yeah. Okay. So many times, clients, caregivers, they will ask if a driving evaluation is legally required. In some situations, they can be, such as if it's court ordered, for instance. But most of the time, driving evaluations are recommended by the patient's physician. Again, the physician is referring out because they want to make an informed decision about a person's ability to drive. Um, they can also be sought out, by family members for their loved ones, or by the patients they have been told to stop driving by their doctor, and they want to show that, that they can still do it. So it's voluntarily for the most part, but again, it all goes back to getting a referral from the doctor saying that it's medically necessary. Um, if the physician is ordering a driving evaluation, they will often recommend that the patient stop driving until the results of the evaluation can be reviewed. And sometimes they just recommend that the patient stop driving because they meet certain criteria in the physician's opinion to warrant driving retirement. In either case, if a patient has a valid driver's license, then they're not legally obligated to stop driving just because the doctor recommended it. Um, or even if they fail a driving evaluation and they have a valid legal driver's license. So there's nothing telling them, legally speaking, that they have to stop. Um, However, if they continue to drive against medical advice, then the patient exposes themselves to significant liability issues. For example, if they go out and get into an accident and they're driving against medical advice, um, you know, if somebody has a decent lawyer, they're going to pull their medical records and see that they should have not been driving, and that opens them up to a significant lawsuit and liability problem. And I talk about this all the time with my clients. So the only way a person can lose their ability to legally drive is if they voluntarily surrender their license to the state. If they do this, they can't get it back. So if they voluntarily surrender their license, they cannot get it back. Or if their license is revoked through the Department of Driver Services. So, because the Department of Driver Services, or DDS, is the only department that issues and deals with licensing. A revocation of the license can occur from either a legal action or as a result of a medical condition that makes a driver unsafe to drive. The medical revocation process can be initiated by anyone, and the person who initiates it can remain anonymous in Georgia. Once DDS receives the complaint, they will send a letter to the driver stating that a complaint has been submitted on their behalf, and they have 60 days to have their physician complete and submit the appropriate documents to DDS Medical Review Unit that either support or deny the driver's ability to drive safely. If the forms are not submitted within that 60-day window, then their license is going to be revoked. So oftentimes, whenever their license is up for revoke, the doctor will refer out for a driving evaluation for these reasons to make that determination on if they're able to safely drive or not. Once a person's license is revoked, it can be difficult to be reinstated, but it is possible. A driving evaluation can be done, but the evaluator will have to contact DDS Medical Review Unit to lift the revocation for a brief window of time to perform the evaluation. And then the revocation is reinstated after the evaluation is over. Then once it's done, the report is filed or sent to DDS. The medical review unit will make a ruling on whether or not the person's license will be reinstated once they receive all the necessary paperwork and review it. So again, it's all through DDS at that point once it's in the revocation process. As I mentioned earlier in the presentation, a patient's self-report of their driving abilities is not reliable, so gathering information from caregivers is crucial. But caregivers, like I said, they are able to observe loved ones and their behavior on a daily basis. They often have valuable insights about their driving ability, but they may be reluctant to communicate them for various reasons. Sometimes they truly do not know anything about the patient's medical condition and cannot speak on their abilities. But other times, it's out of respect for their loved one's dignity and they don't want to negatively influence care providers. So they're willing to initiate the conversation about getting the evaluation done because they might have a concern, but they don't really want to go into detail about what the specific concerns are, or they only give vague reasons like, they're getting older, or they just want an expert to provide an unbiased opinion kind of a thing. So while it's good that they're starting the conversation and getting the evaluation going, not communicating their insights is a disservice to the safety of not only the patient, but others, because they're sitting on critical information about the client's behavior that could be beneficial to the evaluator. So, and then again, sometimes it's out of fear of damaging their relationship with their loved ones. It's due to toxic situations that's kind of developed over the driving situation. Oftentimes, caregivers have had numerous contentious conversations with their loved ones about about driving, and the client is just refusing. So, you can only discuss the driving concerns with caregivers in private. That's what I try to do to kind of get their insights if they're not willing to open up about them in front of the patient. But it's like I said, it's not always the case. Most people are usually willing to open up and provide some kind of additional insight. But like I said, they may not want to for various reasons. And they just don't want to feel like they're ganging up on their family member. So just document the information that you are able to gather and move forward. It's kind of what I do. The patient must provide consent for the evaluation, but sometimes they just refuse to be evaluated at all. A caregiver can provide consent for the patient to be evaluated, but only if they're their medical power of attorney, their healthcare agent, and they're able to do so. So if I don't get consent from the client to do the evaluation and there's no healthcare agent to provide that consent, then unfortunately I can't do it. As a healthcare provider, they have to consent to it. Like I said, our goal is to preserve the patient's dignity as much as possible, but safety is the bottom line. And again, this goes back to poor insight, poor judgment, or compromised insight judgment. Um, Safety is the bottom line. And sometimes drastic measures may need to be taken if the patient's unsafe and continues to drive illegally or against medical advice. You can remove the car, take the keys, unhook the battery. There's all kinds of different things to kind of get it out of their awareness. Because, like I said, sometimes drastic measures may need to be taken. I could tell you a lot of stories, but we're running low on time, so I'll forego that for now. So the OT driving evaluation process, it's like I said, it's a referral from the doctor, and there's an intake process. Then the evaluation consists of two parts. It's a clinical pre-driving assessment and then an on-road driving assessment. I do them all, both of them at the same time in one day. It's a long day. It's about a 4 hour evaluation, but gets it all done in one day. Um, Evaluations for clients with MCI and dementia typically take a little longer, just to kind of get through all the cognitive testing and everything like that. So, like I said, it's like a 4 hour or more process. And then the results and the recommendations are given the same day. A report is also, submitted to the doctor. That usually takes longer, but you'll definitely know the results and the recommendations that same day. So like I mentioned, the referral from the physician is tantamount, and that's what it starts. This is my referral form. This is what I send to all of my clients who want to initiate it, the driving evaluation, and they have to get this filled out and signed by their doctor to start or to initiate the evaluation process. And I also ask for medical records and medication regimen because sometimes, especially with MCI and dementia, the patient is a poor historian. They're not able to remember or, be able to tell what's going on with their medical history. And like I said previously, oftentimes medical history is very important for underlying situations that may not even necessarily be attributed to the MCI or dementia. And then, I verify their license status. Sometimes they're suspended, sometimes they're revoked without the patient knowing about it. So I definitely verify the license status to make sure that it's valid before we do the evaluation, and then the appointment is scheduled. The clinical pre-driving assessment. So this is the first part. This is where I develop occupational profile to kind of determine, their social history, their living situation, what's going on in their life, what's important to them, where they like to drive to, in the community, things like that. Again, medical history, medication review. I assess vision, strength, range of motion, coordination, do brake reaction time, do cognitive testing. Um, Basically everything that we use for driving is what I'm looking at and the goal of the clinical pre-driving assessment is to identify problem areas, you know, and kind of once I determine what those problem areas are, then we do the on-road assessment. And the whole on-road assessment is to determine, are they able to safely compensate for these problems that were identified during the clinical. So just because, like I said, you have a deficit doesn't mean you can't drive if you're able to safely compensate for it. So the on-road assessment is, I'm looking at basic vehicle handling skills, um, applied understanding of road rules. Are you following all the laws and rules of the road appropriately, or are you just kind of doing whatever? Um, Functional assessment of cognitive abilities. So, I'm assessing divided attention, processing speed, memory, all of those kind of things. Whenever I do um, So I do geographic assessments. So I'm a mobile-based business. I only do all of my assessments, where the client lives. So we actually drive to locations that are meaningful to them in their home community. Because it's better than a fixed route assessment because it gives um, me the ability to look at them in their home community and get a better idea of their abilities rather than driving in a place that they're not familiar with and they never drive in ever. And, it doesn't make much sense to put them on the interstate if they're never going to drive on the interstate. So that's the difference between a geographic assessment and a fixed route assessment. And I do all of mine that way. So once that is done, the on-road, then I do the evaluation results and recommendations. That's where I make my determination based off of the clinical evaluation results and then the on-road evaluation results. And there can be various recommendations. These are just some of the most common ones. So, say they did everything great, they're good to go, continue independent driving without restrictions, or resume if they have stopped driving, continue independent driving with restrictions. And these are some of the restrictions that I typically recommend for people because again, you're trying to keep them on the road for as long as possible. So if they don't need to be driving at certain times or in certain areas, then limit that. So that way they can maintain their independence and going to places that they want to go to without having, free reign to go everywhere. And I don't typically recommend restrictions unless there is a family member or caregiver able to actually enforce those, whether it be through some kind of a GPS tracking, which I'll talk about in a minute, to track the patients driving whenever they're out on the road to see that they're actually following these, because they're not going to be able to remember the restrictions a lot of times. Again, cognitive impairment, so they have to have support from family or caregivers to enforce these restrictions. So that's a big caveat with restrictions. Um, Sometimes training, maybe they need driver improvement or driver rehabilitation training to improve that. Maybe they've developed poor driving habits over time and they have now that they have this condition, it's affecting their ability to drive safely because they don't have necessarily the quicker reaction time, or they have those cognitive problems that maybe they were able to compensate for years ago, but now it's a safety problem. And then finally, driving is contraindicated due to safety concerns and driving retirement. So, if I have to intervene for any reason, obviously that's a safety concern, whether it be braking assistance, acceleration assistance, steering assistance, navigation assistance because they got lost. Um, Obviously, driving retirement is recommended in those situations just because they're safety concerns. And then additional recommendations. For this population, for MCI and dementia, like I said, it's a progressive condition. So I recommend recurring reassessment of driving performance, typically about every year, sometimes less. It's really dependent on the doctor and how, often they want to have it done, but usually no longer than 12 months. Um, GPS navigation for navigation assistance. This is primarily if they've already been using it for a long time and they know how to use it. And again, if they do that, then I assess their ability to do that during the evaluation. Are you able to pay attention to the GPS while also paying attention to the road? Because that's dividing your attention and alternating your attention between two things. So, I assess that stuff. If they've never used GPS, I'm not going to try to teach someone with cognitive impairments to use GPS. So I typically won't recommend it in that situation. Tracking technology and monitoring services, like I mentioned, I usually recommend that a lot. There's some that are on the phone. A lot of people have those for apps that you can kind of track there on the phone. But if they forget to bring their phone or they don't take their phone with them, I also recommend one that it plugs into their car so you can track them and their phone, but also the car. Because sometimes if they get lost and turned around or whatever, they get out of their car. So maybe you can track where the car is, but not where they are. And then in some cases, adaptive equipment. There's tons of different adaptive equipment. blind spot mirrors, panoramic rear view mirrors. There's a lot of different things that can kind of help um, improve sight lines and being able to check blind spots, things like that. But also, other equipment like left foot accelerator pedals, for instance, if they have hemiplegia or hand controls, things like that. But again, it's few and far between on adaptive equipment if I recommend those because, again, teaching them how to use that adaptive equipment can be difficult with this population. And then finally, driving retirement considerations. Like I said, it's necessary if safety is compromised and there's no chance for improving their driving skills through training because they're not able to implement the uh, instruction that's being given to them. So the next steps, like I said, the patient turns in their license voluntarily, or the physician completes DDS forms to have their license revoked for medical reasons. And like I mentioned, it can turn into a contentious situation. Patients may continue to drive if the vehicle is available to them. So, I've heard of people driving with a revoked license against medical advice completely illegally, just because the car is available to them. So that's kind of those drastic situations you have to take at certain times. And then emphasize the positives of not driving and ensure them that they can continue living a fulfilling life and provide alternative transportation options. Like I said, um, nowadays with Uber and things like that, I mean, there's a lot of alternative transportation options, especially, in kind of the urban centers. It's more difficult out in the rural areas. But there's a lot more today than there were, 20, 30 years ago. And honestly, things like having things delivered to them. A lot of times my clients say, well, I just want to be able to go to the grocery store or do this or, go to the get my prescriptions. Well, I mean, you can have your prescriptions delivered to your doorstep. You can have your grocery stores delivered to your doorstep. You can have food, from restaurants delivered to your doorstep in the world that we live in today. I mean, you can have anything pretty much delivered to your doorstep in 2 days. So there's a lot of options available to them. And if you kind of reframe it of how to live their life in a different way that doesn't involve driving, that can help them continue living a fulfilling life. Okay. I think we made perfect timing. Who's got questions?
Dustin, that was fantastic. Thank you so much. It's a
No
lot of
problem.
information, but I think it really answers a lot of the mystery around driving evaluations. And we refer quite a number of folks for driving evaluations.
Yeah, absolutely.
Michael says, thank you very much. If there are other questions or comments, please put them in the Q&A section. You should be able to find Q&A on your Zoom toolbar, or you may have to click on more to find it under more. One question that did come in was if somebody has a driving evaluation, and this can be for you, Dustin, and maybe for some of our social workers as well. If somebody has a driving evaluation and it's determined that they need to retire from driving, does that also necessarily mean that they are no longer able to independently navigate other forms of transportation like MARTA or Uber?
Oh, that's a good question. And no, it doesn't automatically disqualify them. I think if there are concerns, you should absolutely get them connected with an OT. I typically stick with just driving. That's what I specialize in, but I would definitely get them with an OT and do some OT with community mobility for those kind of things, being able to navigate the community, utilize Uber, MARTA, things like that. Hope that answers the question.
Yeah, that's very helpful. Another question that has come up is when, I guess you touched on this throughout your discussion. Very often one of the questions that comes up is that folks don't want to end up in what you named a toxic situation around driving and the independence. folks feeling like their independence is being taken away, regardless of how we reframe it or what we
Mhm.
focus on. Would you recommend, and in those situations, would you recommend that the care partner work with the physician to be the one to kind of say, hey, we need to have a driving evaluation, rather than having the care partner be the fall guy, if you will?
Yeah, I mean, absolutely. And I tell my clients all the time, and care partners that I work with is I'm very comfortable and oftentimes need to be the bad guy that has to say, you can't do this anymore. But yes, the answer to your question is yes, they need to, because again, safety is the bottom line. And we want to maintain dignity and independence for as long as possible, but you have to consider, if there's a potential for them to injure themselves or somebody else, God forbid, on the road, then, you don't want to have to live with that. So absolutely, sometimes you have to step in, and I think they should absolutely go to the doctor and say, hey, we want to avoid those toxic situations or to get out of the toxic loop, if you will, because they've already had the toxic conversations many, many times. So, they definitely should talk, go with them um, to, their neurologist or their doctor and say, hey, we want to get an evaluation. So that's what I was saying about advocacy. It's very important to kind of be their advocate because, in their minds, there's nothing wrong.
Absolutely. And I think that's a really important point as well. This isn't necessarily about being stubborn. This is about the cognitive challenges that come with dementia, and a very real belief that their driving is not affected at this point, or not affected enough to be an unsafe driver.
Yeah.
And
I
that's why
mean,
we have to step in and have the evaluation.
for sure. I mean, it's kind of equivalent to eloping, You have to take certain steps to prevent eloping, and sometimes they have to be drastic steps because they could injure themselves. So, I mean, in these kinds of situations, you have to kind of take the necessary steps for that.
Dustin, thank you so much. Really, really appreciate you being here today. I don't see any more questions at this point, so we'll finish up for today. Next month, Paul Black will be coming and speaking with us about some of the legal concerns that come with mild cognitive impairment and dementia. And Dustin, again, this was fantastic. Really appreciate you coming today and
No problem at all. I had
making some
fun.
of the mystery out of this for us.
Yeah, absolutely. And like I said, I'm your resource for everything driving. So if you ever have any questions, please reach out.
Great. Thank you so much.
All right. Have a good one.
Bye, y'all.
Bye.